So hello everyone, thanks for coming. A few people will still flow in. It's an unusual room, this is why some people might take a little bit longer. It's a great pleasure to announce this or introduce this talk. We have Charles Taylor today here visiting with some of the team from HeartFlow. So HeartFlow is an exciting company, and we just recently started a very nice collaboration. Just the opposite of this lecture room, the BioMedIA lab is now actively working with HeartFlow together. We actually do have HeartFlow researchers who also have an affiliation with Imperial working just across the lecture room. But it's my great pleasure to have Charles here today. Charles holds a PhD from Stanford University, and just after his PhD he joined the faculty at Stanford as well. He started a research group there working on computer modeling and image-based techniques. He pioneered work on blood flow simulation already for the idea to work on cardiovascular disease. And after 10 years being faculty at Stanford, he thought it's a good idea to start a company based on this fundamental research that they started back at Stanford. And I guess they still have very close links to Stanford. Charles is still a professor in the biomedical engineering there, also professor in Eindhoven. And today he's basically giving us a snapshot of that exciting journey that HeartFlow took from fundamental research, working on algorithms, on modeling, things that we do at university, but they then took it into a company and developing a product that now actually benefits the lives of thousands and maybe millions of patients suffering from cardiovascular disease. So it's a great honor to have you here, and Michiel as well, and Gina from HeartFlow, and we're looking forward to this talk showing us this exciting journey. Thanks very much.
Thanks, Ben. Thank you. Thanks. I have to say, of all the years I was in the field, this is my first visit to Imperial College, which I think is long overdue. I think some of the first work that I had read about, some of the research that I had been familiar with was with Professor Colin Caro. His work, I think it was a 1974 paper in Proceedings of the Royal Society on looking at how flow characteristics were influenced in the development of atherosclerosis. And this is really, one of the world's best places in the field in cardiovascular engineering and obviously in computer science. And it's just a pleasure to be here and to also to be looking around an office space in London and bringing hopefully a big team here to London. So I want to start and talk a little bit this journey to talk a little bit about the work that started off at Stanford, and then I'll tell you about how this was then we translated this and then brought this into a company, HeartFlow, and some of the work that we're doing in clinical areas. So I recognize this is probably a very diverse audience, people from computer science, from biomedical engineering, maybe physicians cardiologists working in the field, or radiographers. So I want to try to balance a little bit of the technical side and a little bit of the clinical side. So I'll do my best here. So the first some of the first areas and how I got involved in the field was a chance encounter at Stanford, meeting this fellow Chris Ahrens, who just came into Stanford and started our vascular surgery program at Stanford, and I was in the engineering school and working on my PhD in a totally different area, and actually developing computational methods to do air flow over airplanes. So it's actually funded by the U.S. Air Force on a project. It was very interesting. I went to see this talk, Blood Flow in Your Health, by this fellow. He started talking about how experimental methods to describe blood flow in glass models of arteries was yielding insight into fundamental development of atherosclerosis in the body. And Chris was quite a unique character, but it was also unique because he collaborated with one of probably the foremost pathologists, cardiovascular pathologists of the last century, Seymour Glagoff, and also with an engineer, Don Giddens at Georgia Tech. And they were, again, looking at this relationship between engineering and fluid mechanics principles in development of disease. And what they observed is that how plaque develops in the carotid artery that ultimately can lead to stroke was developing in areas where the plaque was depositing in areas where there's flow stagnation or low shear stress. Also in keeping with Colin Caro's theories, from almost a decade before. as this experimental work was developing, some computer scientists, mathematicians were starting to think about the possibility of developing computer simulation methods. It's can be quite difficult, challenging to build glass models and to understand fluid mechanics behaviors. So this guy, Karl Perchtold, a mathematician, computer scientist in Graz, Austria, really did some pretty amazing work in the field. Jimmy Moore here, now at Imperial College, was doing work in looking at flow through glass models and using magnetic resonance imaging techniques to actually describe flow characteristics and understanding flow under different physiologic states. I started working at Stanford as a graduate student when I was working with Chris Ahrens, and also a professor and kind of applied mathematician, computational mechanics, a field that Stanford Tom Hughes, kind of one of the authorities in computational mechanics and fine element methods, in developing computational methods and trying to develop methods for parallel computing for describing complex flow characteristics. I was in the lab one day at Stanford, and we had a new faculty member there. He was actually a radiologist, a junior faculty of radiology, and he had just written one of the first papers in CT angiography, using spiral CT imaging with contrast to image the abdominal aorta. This fellow is Jeff Rubin. And I remember seeing this in images from this patient. This is a computer model that we constructed for that patient. And I had this notion that if we saw the image data, we could actually maybe extract the geometry from the image data and do a patient-specific model of blood flow, simulate blood flow. Mostly wasn't really a clinical application of that, but it was kind of cool, right? It was interesting. In Silicon Valley, we would talk about BHAGs, which are referred as big, hairy, audacious goals. So a couple of weeks before the supercomputing show in 1995, a group of people came in and said, do you want to show off some of your stuff at supercomputing? And I said, yeah, but I want to do something different. So in that 2-week period, we've basically used all the computing resources at NASA at that time to simulate blood flow in this patient's aorta and looking at flow characteristics. Again, not a terrible practical clinical application, but it was just, could we do it? And we started thinking, what could we do? If we could actually do simulations of blood flow, how could this actually impact patients in the clinic? And remember, I was in one of the vascular surgery rounds, and there was, at Stanford, we'd have all the faculty vascular surgeons come in from all over the Bay Area, and they talk about their patients. I remember one particular fellow who came in and talked about his patient. He said, and I did this operation in 1989, this one in 1990, this one in 1991. I thought, wow, wouldn't it be great if we could figure out some tools to try to predict what might happen as a result of a procedure, predict the benefit of a surgical procedure before you do it, and actually bring essentially design tools, computer design tools into the clinic to try to predict outcomes of interventions. Now, obviously, the body is extraordinarily complex. It's a BHAG, an audacious goal to think about trying to consider doing that. But we started to talk about this idea. Wrote a paper called Predictive Medicine, and we were developing tools. This is so long ago. This was pre-release versions of VRML2. Probably nobody remembers that, but some of the Java application to be able to do interaction with a 3D model and Sketchpad for surgical plans, et cetera. But this is 20 years ago. They were doing this, and we had a panel of vascular surgeons up at one of the major meetings, and you see their Silicon Graphics computers out in front because that's what we had to do to drive these big, terminals, and actually got them to interact with a patient's model and patient data and plan a procedure on stage. It was just a lot of show, but it was really kind of captured the imaginations of a lot of physicians in the room, the idea that maybe the future of the field could actually involve interacting with computer models of patients and predicting outcomes of interventions. Now, at the turn of the century, the challenges in modeling blood flow is that the methods of the models were emerging. The idea was really taking off, but there wasn't really any software to create these models for medical imaging data or segmentation methods. It was pretty early stages of actually extracting geometry from image data. The CFD methods were being used to solve for velocity and shear stress, but it wasn't actually feasible to accurately predict flow distribution or pressure fields for a variety of reasons. Methods for incorporating the kind of compliance wall deformability, it was limited to simple idealized models. there wasn't really any validation out there of the computational methods, and the methods really were being used for scientific, but it wasn't really clear what the clinical potential of this technology was. So in the first decade, my team at Stanford, a lot of fantastic graduate students, we started to break this problem apart, and I had a large grant from our National Science Foundation to really build the core technology in my lab, a 5-year, multi-million-dollar grant to start to develop the tools for image-based modeling, centerline extraction, and geometry creation. We're trying to describe more realistic models for physiology of boundary conditions, coupling really multi-scale modeling, coupling models of the large arteries with models of the microcirculation, parallel solvers, and we were using a lot of really high-performance computing to be able to simulate flow, and then also developing methods to do large-scale fluid-solid, fluid-structure interaction, model the deformability of blood vessels. And this is actually starting to think about clinical applications. And I was also at an appointment in pediatrics, and this is a patient with aortic coarctation, and there's just considerations about these are actually collateral vessels going in the patient around the restriction in their aorta, a young child. And we're trying to think about how do we use this to guide decisions about interventions. When do you do a surgical procedure to repair some of these anomalies? From a mathematics perspective, we really had to go back. It wasn't something that we could use existing software to be able to model blood flow. Just was not set up for that. So we had to really think about developing methods, multi-scale methods, where we could think about the region of interest, domain of interest, and couple it to other models of the microcirculation. And really had to go back to first principles and the computational methods, and reformulate the problems and into ways of coupling downstream with upstream models. And this is, I think, one of my brightest students in my lab, and one of the most cited references, and really laid the foundation for actually doing realistic flow and pressure simulations. Also started to think about how do we couple elastodynamics equations with the fluid domain and the equations of fluid flow and wall dynamics, and had this kind of idea for a pretty simple approach, but one that proved to be incredibly powerful, because we could start to look at flow. This is a idealized model of a restriction in a vessel, and see the turbulent flow coming through it, and it's basically causing vibrations in the wall and dynamics. And as we started to do this, as vessels wiggling around, we thought, okay, we got to think about external tissue support to be able to really model what's really happening in the body. And then kind of went along those lines. But to really start to create the machinery for doing more complex things. This is the last of my graduate students before I left, and he ended up going on and being advised by Alberto Figueroa, who was here at King's College and now is an associate professor in bioengineering surgery at University of Michigan, but took the methods developed in my lab to do really large-scale problems, head-to-toe simulations of blood flow and pressure propagation in 3D. And again, this is just, a problem. And there's a lot of interesting clinical issues that can be explored, like the effect of aging on changes in blood pressure. There's a lot of interesting questions. So we also did a lot of work to basically go back and say, how good are these methods? And you can't do much when you have a computer method. The mathematics and going back to mathematical models, it's really very limited in terms of the analytical or closed-form solutions that you can have. But there's a really elegant theory. It's called Wormsley theory, and you can basically describe pulse wave propagation in an elastic vessel, a mathematical equation, and there's dots here, which are the numerical method, and superposed on the curves, the solid curves, which are analytical solutions. Because we had to say, okay, how well does this work? How do we verify our numerical method against mathematical solutions? And did a bunch of work in that area. Started to then compare the numerical solutions to physical models. And this is a laser Doppler anemometry data from a fellow that Jimmy knows, Frank Loth, and validating predicted versus measured curves. We did a lot of imaging with phase contrast imaging to measure flow characteristics in physical models and aneurysms and pressure wave propagation and all that kind of stuff. We kind of got to the limit of, okay, now we've done as much as we can do in physical models. We started to then look at animal models, and we actually had a animal surgery suite right next to our imaging facility, and started to think about taking this into animal models. towards the end of my time there at Stanford, we really started to focus on this one particular problem, blood flow in the coronary arteries in the heart. And one of the tremendous challenges associated with this is that to try to model flow through the coronary arteries, it's such a coupled problem. It's really associated with flow through the coronary arteries is driven by aortic pressure, but must be accommodated by the resistance of the circulation, which changes over the cardiac cycle because the vessels are penetrating the myocardium and they're constricting and relaxing over the cardiac cycle. So they're accommodating flow as the muscle of the heart is relaxing, but that's actually when the pressure is starting to fall. So you actually get peak coronary flow at the time where aortic pressure is falling. And trying to model that dynamics is quite complicated. So we had to figure out how to do that, and it turns out you could actually develop like a closed loop model, use simple models. Is a really elegant, it's just electric circuit model, but it's actually a really elegant model of the functioning of the left ventricle. You can describe a heart model to drive aortic pressure, couple it to a 3D model, and then put downstream boundary conditions or microcirculatory model that lets you change the time-varying, basically simulate the time-varying intramyocardial pressure, the compression and relaxation of the muscle of the heart. And you can do that and then start to think about how do we do patient-specific modeling of coronary flow. This is one of the last papers and that came out of my lab at Stanford to try to simulate the wall dynamics, the pressure characteristics, flow characteristics through the aorta and then into the coronaries. So that was, that journey, again, it was actually over the course of 15 years from the first patient-specific models to getting to the point where we could actually do realistic simulations of blood flow in the coronary arteries. There's a lot of technologies that we had to build along the way, ranging from, image segmentation methods or mesh generation techniques of physiologic models, et cetera. There's a couple of review papers that I wrote with some colleagues on patient-specific modeling of blood flow. And of course, any journey starting in the academy, obviously it really requires a tremendously bright, talented students, and these are the graduate students and postdocs that came out of my lab, and many of them in industry, some in the government at FDA, US FDA, some many in faculty positions as well all over the world. So let me take the next step, the next chapter of this story, which is really the translation of some of these ideas into the clinic. And I'm going to take a step back and tell you a little bit about coronary artery disease for some of you in the room that are not that familiar with the burden of heart disease. It's a global problem. It's a third of all global deaths. About 2.3 million people in the UK have coronary artery disease. It's responsible for over 66,000 deaths in the UK each year, which translates to a death every 8 minutes. Large expenditure in healthcare costs. Again, not just direct costs related to the procedures that are done, but a lot of indirect costs as well. And one of the challenges that we see in the UK, we see this in the US and a lot of other countries, is that you see an increased burden of coronary artery disease with advancing age. This is the numbers of cardiovascular disease increasing with age. This is cancer, respiratory diseases. And what happens, of course, is there's a higher prevalence of disease as people get older. And then the demographic changes that are occurring here in the UK, that's also true in the US and worse in a lot of other places, Japan, and even China. You really have this kind of change in population pyramid where, now it's, you have a certain number of people in this age range where they're susceptible to heart disease, and that number of people is increasing. And you have to look at the base of the pyramid to think about, the people of working age are supporting this increasing number of people that have heart disease. And this translates to a significant problem. In the US, it's expected that the cost of treating patients with coronary artery disease is going to roughly double in the next 10 to 15 years, and we're talking hundreds and hundreds of billions of dollars. So the challenge is we have demographic changes will result in more need for more tests and treatments for patients. We have to figure out a way of reducing costs of tests and procedures and or perform fewer tests and procedures. So coming back to coronary artery disease, what happens when they have a patient with suspected coronary disease? If they have it, if the disease is relatively simple, can often be treated with optimal medical therapy. drugs, lifestyle modification, etc. If the disease gets more severe, then you have to think about stenting. Perhaps you need to revascularize with the stenting procedure. If it's very severe, then bypass surgery is often necessary. Of course, these are increasingly invasive and expensive procedures. To decide on revascularization, it really requires an understanding, is there some anatomic narrowing, what we call obstructive coronary artery disease? And in addition, is that narrowing limiting blood supply to the muscle of the heart? Both of those are needed to warrant any revascularization approach, stents or surgery. In particular, to think about stents, to kind of narrow this down a little further, you need to look at disease that is focal in nature, and also the lack of blood supply to the muscle of the heart is attributable to that particular lesion that you're considering stenting. Both of those are needed to warrant interventions. Well, how is this information obtained for a patient that walks in with chest pain and a suspected coronary disease? How can this information about anatomy and function be obtained? For invasive procedures, again, gold standard for obtaining anatomic and functional data, the first procedure is looking at invasive diagnostic cardiac catheterization. Really, the goal is to find those patients that need therapy, which patients can be treated medically, which patients require stenting, percutaneous coronary intervention, or bypass grafting. It's really the gold standard is the determination of looking at a narrowing in the coronary artery, and the typical definition is a greater than 50% diameter stenosis. Where did this come from? It turns out it came from a series of animal experiments about 40 years ago, animal experiments in dogs, showing that increasing a narrowing in a left anterior descending coronary artery of a dog, when you got to about 50%, you would start to see a fall in blood flow under stress conditions. It's the experiments of a fellow, kind of a grandfather of coronary physiology, Lance Gould. As time went on, it was recognized, actually about a decade after that first work, that simple animal model really didn't work or didn't hold up in humans. There was a paper written about 30 years ago that really kind of questioned that principle, but yet that is the principle that has really most interventions are still performed based upon that criteria of a diameter stenosis. A couple of decades ago, these physiologists, one in Eindhoven, one in Belgium, Netherlands and Belgium, developed this technique, this idea of putting a pressure wire down the coronary arteries and measuring pressure under stress conditions. So they'd use a drug to simulate stress conditions under physical activity. And they measure pressure downstream of the coronary stenosis and then in the aorta at the same time. And this ratio of downstream pressure to aortic pressure, if it's close to 1, it means there's no limitation of blood supply through the disease in the coronary arteries. It's fine. That's what would be called non-ischemic. If it's actually in that non-ischemic zone was defined as greater than 0.8. If it was less than 0.75, it was in a zone called clearly ischemic, clearly limiting blood supply to the muscle of the heart. So downstream pressure, 75% of the aortic pressure, clearly ischemic. And what this technique, they call this metric fractional flow reserve. And did a remarkable set of clinical studies and experimental studies, over the last couple of decades, really defining this technique. And two of the most important papers that were written in studies that were done were called FAME and FAME2. And this first study showed is that if you use this technique, this invasive pressure wire measurement, to guide whether you would treat a patient or not in the cath lab, then you would get better results. Patients would live longer and actually fewer stents, and the cost would be less if you guided patients with this physiology information versus that anatomic rule, the 50% stenosis. This is really important study. What they then had to prove is on the other side of it, if patients had low values, that there was actually a benefit of stenting. Because you could posit that based upon this first study, well, that's just because nobody benefits from stenting and any patient should just be treated medically. But what they demonstrated, and this was just published a couple of weeks ago, again in the New England Journal of Medicine, is that as you looked at patients that had tight stenoses, limiting blood supply to the muscle of the heart, that as time went on, those patients were at greater risk of spontaneous myocardial infarction, spontaneous plaque rupture, and heart attacks. So they basically really demonstrated that there are patients that really benefit from revascularization, and this test can help separate those who can be treated medically from those who can be treated with with interventional techniques. And now there have been a paper came out recently that shows that this also is really valuable for identifying patients that would benefit from surgery, bypass surgery as well. So that's great. We got this great test, anatomy, physiology, everything's great. But both of these require invasive cardiac catheterization, angiography and FFR. The issue is that most patients that enter the cath lab actually will not have a positive test, will not have both of those tests positive. Most patients enter the cath lab don't have obstructive coronary disease on angiography, let alone a positive FFR. So this is what really prompted me to think about this idea. You know, now I guess 9 years ago, almost 10 years ago, that maybe we could actually identify obstructive coronary disease and lesion-specific ischemia before the patients go to the cath lab. That was the idea, kind of the big idea that ultimately led to HeartFlow. I was on sabbatical from Stanford and you know, thinking about what I wanted to do next, you know, in my life, and started and was very familiar with what was happening with non-invasive imaging and CT, remarkable data that was being obtained from CT, and then had the question, okay, what about this? How do we do this? Well, the challenges of the existing tests that are available, you can CT, again, it's beautiful anatomic resolution, you see a tight coronary stenosis, but you do a nuclear test on this patient, it's negative. Its red is negative, and you don't identify disease that maybe is probably life-threatening for this patient, certainly very significant and warrants invasive assessment, but you miss it with a lot of tests. And there was a study that was done, again, this is published in first paper in 2010, nearly 400,000 patients. So what they found is that during invasive coronary angiograms, all these patients that had these other tests beforehand, these stress tests, you take them to the catheterization lab, and more than half of them are negative. You have a positive functional test, more than half of them are negative. They have no disease. And they could have actually avoided that invasive test, catheterization test, if you had a better screening tool. So this is also a paper that was published a couple of years ago, and the finding of this, of the patients with a positive stress test were actually the ones that were least likely to have obstructive coronary disease or get revascularized. So this is published in the journal JAMA Cardiology. This is out of Duke. You know, I think it's 15,000 patients. So that's pretty remarkable to think about that. So what do we do? Is there a better way to do this? And this is the idea that I really focused on. As I was modeling blood flow and pressure in other parts of circulation, I thought, is there enough information out of a standard coronary CT scan to try to inform a mathematical computer model, simulate blood flow through that patient's arteries, predict this pressure change, and see whether it's a better way of identifying patients that might benefit from further invasive assessment? So I started the company in 2007. It was really first to commercialize patient-specific blood flow modeling technology from my lab. And then it was, you know, shortly afterwards, I focused the company on this idea of the non-invasive fractional flow reserve. So there's over 300 people in the US, Europe, and Japan as their first product. We're very proud of the fact that investigators have written a lot of papers. There's a lot of literature coming out. We fund a lot of clinical research, and we're really excited about that. And we also have a very creative, inventive culture, and we write a lot of patents. I write more patents than papers these days, but that's just kind of the nature of being in an industry. We have clearance in Europe, in the US, and in Japan, and it's being used clinically in these places. So when we produce a result, we do this simulation of blood flow. Then what we actually get back to the physicians, they get an email that tells them that their case is done. They can go to our interactive viewer, see the whole coronary tree for the patients, click interrogate values, numerical values, and get information about their patient. They can also do this on a mobile phone, on an iPhone, or an iPad as well to get information. Oh, that's not good. It's Microsoft's fault. See? Creating software is hard. We'll have to restart here, and I'll skip over that. This brings to mind, at that demo that I did in the Society for Vascular Surgery meeting, one of a couple of weeks before, Bill Gates had done this big unveiling of Microsoft new system in it live. And I don't know if you remember that, this is 20 years ago, but it was a complete dismal failure. With all of the resources of Microsoft, nothing worked. And that was, we were kind of going into this big show in the Society for Vascular Surgery, and it was very scary because, of course, the fear was that we were going to run into these problems of, you know, a small group of Stanford people, that we were going to run into these problems of having software crash in front of all the thousands of vascular surgeons. Fortunately, that didn't happen. But again, it was Microsoft. Not me. Nothing against Microsoft, but you know, they still got some bugs in the system. So the analysis process, what do? We start with CT data, and we build an anatomic model, actually use information from the anatomy to simulate physiology, use form-function relationships. How I describe this often is that it's actually a lot of information about physiology encoded in our vessels, in the size of our vessels, and the amount of tissue we have in our heart. Because our vessels, our vascular system adapts continuously to the amount of flow. So you can look at the geometry of the anatomy and actually infer information from form to function. Then we have to simulate flow and produce those results back for physicians. So we start off with a standard cardiac CT scan. Is done, you know, anywhere on the planet. We have a software, virtual machine, software running a virtual machine that we install on site in the hospital's network. They push the data through the firewall into our application running on Amazon Web Services. Again, any standard coronary CT. When that comes in, then we create a fully automated anatomic model. We use deep learning methods to create this personalized digital 3D model. Then we have people inspect and correct it. And this is really the cool thing. What really makes deep learning methods possible is that to have the physician interpreting the data, to send it to us, to upload it, to create an automated model, and then have people inspect and correct the model. Because you create this virtuous cycle where the corrections train the algorithm improves, less corrections are needed. So we're cycling through this, and of course because we're regulated, we don't update our software every day. We don't release our software every day or many times a day. We release it actually every couple of weeks. But the algorithms get updated more, you know, on a less frequent basis. But it makes it possible to continuously improve and learn from the data. Because we have a lot of data, we have a model that gets inspected and corrected. And then we have the physiology model and the report, the results that come back. So large quantities, rigorously annotated data. So, of course, in this audience, many of you are working in the area of developing deep learning methods. You're very familiar with it. I won't say much more than that. We started off with more conventional machine learning methods, and I think we got to the point where we're seeing saturation of the performance, and really seeing some great results. And of course, in medical imaging, this is probably one of the most talked about topics, certainly in the radiology circles, and just, you know, all of the things that are exciting and possible. So what happens when we do this? We can't just use deep learning methods right out of the box. The results are very unsatisfactory. The segmentations are blocky. We get kind of spurious components. So we really have had, and Mikhail Shup has led the team, some really brilliant experts working at this intersect between deep learning and medical image analysis. And of course, this is why we're here and collaborating with Daniel and Ben and the team, is to really take this to the next level. So the Deep Lumen, our algorithm called Deep Lumen, is specially designed for segmentation of the coronary arteries. I won't go into the details. Mikhail, I think, talked about this the last time that he was here. And there's a couple of references from one of our scientists, Kirsten Peterson, doing some of this work. So the results are great. I think we're seeing, again, specialized algorithms, you know, very nice performance addressing some of these limitations of other techniques. We're training this now we have a repository of over 20,000 cases from 64 slice CT scanners. We're starting to see more, you know, ethnic anatomical variations. And we're looking at a performance right now. This is just hot off the press, where we're looking at the performance of a CT read from expert read versus angiography, and you see the kind of level of performance. This is 470 measurements, a correlation coefficient. We're matching that performance with a fully automated algorithm using deep learning. That's really exciting, you know, and we are truly getting to the point where human annotation actually will not improve the performance. Will actually degrade the performance of the algorithms. And this is kind of a new way of thinking. We have people in the loop in inspection and correction of algorithms, and we've got to think about how do we actually maximize human interpretation with algorithms that really perform phenomenally well. We test these rigorously. We do things like, this is a test with the gold standard for invasive imaging, optical coherence tomography, OCT. We're looking at the lumen boundary perfectly delineated with that technique. This is what you see from CT. We've co-registered the OCT to the CT data to compare the results. This is published just this year, a few months ago, and we're seeing results where the performance that we're getting from an automated system is outperformed everything, all of the other published literature in comparison to invasive data. That's exciting. This is really the foundation of the method, to be able to get an accurate anatomic representation from image data. And it's hard because the image data is often very noisy. Highly diseased patients are very difficult. You look at the data set and you're like, wow, how could a person ever sort that out with the disease complexity? So what the next step that we have, and this is kind of our third generation of algorithms that we're working on now, is how do we actually use invasive data in a group of patients to train up the algorithms and essentially remove human bias, and I kind of give the analysts, our analysts X-ray vision, or the algorithms X-ray vision, where you're really looking at, in a group of patients where you have additional enriched data. And I really believe we're going to be at the point where we'll be kind of greatly exceeding human performance and interpretation of data, within the next year. So the next step is the algorithms to solve blood flow. Simple. This is actually the easy part. Nowadays, easy part, of course, it was the physical laws of fluid dynamics. We've known these 170 years, Navier-Stokes equations. This first states blood is an incompressible fluid, and this second nonlinear set of partial differential equations is just a generalization of Newton's second law, F equals ma to a fluid. I love this quote from Feynman about using mathematics to understand nature. But we can then simulate flow through the coronary arteries, map out. This is actually the speed of blood going through this patient's coronary arteries. Again, this is now the easy part. A more challenging part from a clinical perspective is, how do you describe, with the limited amount of information you have in the CT scan, how do you actually figure out what's going on? If the CT scan's static, it's just an anatomic representation. But how do we actually understand the dynamics of blood flow looking at that static scan? So this is a very simplified description of what we're doing. It's a little bit more complex and sophisticated. This is published in a clinical journal, Journal of the American College of Cardiology, 5 years ago. The kind of foundations of the method. And the idea is we look at the amount of muscle in the heart. That actually gives us an estimation of the amount of coronary blood flow. And I'll show you data in a minute about that. Then we look at the network, kind of the fingerprint of that patient's coronary arteries, and we use that to understand how flow is distributed through the circulation under resting baseline conditions. And then we simulate the action of the drug, adenosine, to predict the changes in resistance under hyperemic conditions. So the first principle, again, flow is proportional to the amount of myocardial tissue. This holds up perfectly in animal models. In measurements, you can use microspheres and to try to test this relationship. It's really almost a perfect correlation. In humans, it's not a perfect correlation, but it's actually blood flow to the tissue of the heart under stress baseline conditions is pretty well preserved. It's around 1.1 milliliters per minute per gram under resting conditions. Under stress conditions, it varies. But under baseline conditions, it's relatively well preserved. That was a study with water PET. This is a more recent study with MR imaging, and shows, again, under stress conditions, it varies for all these different normal controls, patients with low microcirculatory resistance, high microcirculatory resistance, patients with a positive FFR. There's no statistical difference in flow under baseline conditions at rest, but even though it's varying in stress conditions. So it seems like a pretty plausible description of relating the amount of tissue to the total amount of flow. Then we've got to figure out how to divide it. And the idea here is we can look, again, this idea, vessels are enlarging based upon the amount of muscle tissue in the myocardium they have to supply. So we can look at the size of the vessel and understand the region of tissue that it's supplying. This kind of local region around a small vessel, a larger region around a bigger vessel. And the idea is that the amount of territory is driving coronary artery flow, which then drives the size of the feeding vessel. So this is principle. These are relationships between flow and vessel size and coronary circulation, cerebral and brachial circulation, and it's just a little bit less this flow proportional to diameter to some power. This exponent is around 2.7 or so, roughly, a little bit less than 3. And there's a lot of reasons for that. And if you look at optimizing flow characteristics or loss coefficients in the vascular system, you kind of arrive at this number. So what this means is that then if we look at every outlet, the microcirculatory resistance is inversely proportional to diameter to that power, and we can estimate how flow is going to be distributed through the circulation. The reason why this works is that, again, vessels adapt to flow. This is an experimental study in a rabbit model where you increase flow through one of their iliac arteries by connecting the artery to the vein. You dramatically increase flow compared to the flow on the other side. This vessel has much higher flow. It enlarges, it gets bigger. Over a period of about 4 weeks, the vessel adapts in size until the forces acting on the wall renormalize. And it's a pretty remarkable phenomenon. It's called shear stress autoregulation. And there's been a lot of great work in that area. Again, vessels are adapting to the amount of flow. Therefore, if we look at the size of the vessel, we have insight into the flow. And then we simulate the changes in microcirculatory resistance. So it's the process, and we simulate flow. We provide these results back for every patient. How does it work? So that's, of course, the big question. The big question when I first started the company and was trying to raise money was like, yeah, sounds interesting, but does it actually work? And this is what we had to prove. And in the end of the day, we demonstrated that performance in diagnostic accuracy, sensitivity, specificity, this is our last test. It was much better than CT, which was sensitive but not specific, and better than some of the other functional tests, which were specific but not sensitive. The most recent study that we had that was just a few weeks ago presented is comparing a performance versus invasive measurements, an accuracy of 90%, sensitivity of 90%, specificity of 86%, and accuracy of 87%. This is what's called the receiver operator characteristic curve. The closer this is to the kind of this segment, this corner, the closer the value, the area under the curve is closer to 1, the better the result. We had a 0.94 compared to the other tests. So a much better diagnostic performance than CT alone, nuclear testing with SPECT versus PET, water PET, which is the gold standard for perfusion imaging. So this is a patient at CT. You see disease in the CT. Nuclear test is completely negative. This is what our test looks like. Very positive. This is a published study, and these are the measurements, showing very low values of invasive FFR. That was well predicted by our test. We then set out and said, okay, what happens if you guide management of patients with this technique? We did a trial called Platform. We took a group of patients on their way to the cath lab, and separated. Some of those just continued on to the cath lab. A different cohort of patients had CT followed by this test, this non-invasive FFR. The usual care group, 73% of the patients in the cath lab had a finding of non-obstructive disease, didn't get treated, didn't get revascularized, had an invasive diagnostic test but no treatment. And in our arm, we had canceled 60% of the catheterizations. There were only 12% of patients that had a finding of a negative a non-obstructive disease, and the same percentage of patients that had significant coronary disease. There were no any of the patients who had their catheterization canceled. There were no adverse events. They did great. They did fine afterwards, based upon that strategy. It turns out it didn't change really the percentage of patients that would get revascularized, stented, or surgery. It just reduced the diagnostic catheterization rate dramatically. When you do that, actually, in most healthcare systems, you save a lot of money. In the U.S. healthcare system, you'd save $3,000 per patient, billions of dollars of healthcare savings with actually a better clinical result and a better experience for the patients. So some of the milestones, being here in the UK is really important. A few years ago, we started through this tech evaluation committee, NICE, which is really the most rigorous tech assessment process in the world, and they evaluated our technology, had a positive recommendation, and then the U.S. insurance company, big insurance company, Blue Cross Blue Shield, followed afterwards. American Medical Association, the U.S. Medicare had reimbursement, And then NHS England, April 1st of this year, we got an award from NHS to be able to introduce and bring the technology into the UK healthcare system. In the US now, there's I think about 250 million people have their insurance, private or public insurance pays for this test now. Here's a recommendation from NICE in the UK. Just said it's supported by the evidence, non-invasive, safe, and high level of diagnostic accuracy, may avoid need for invasive angiography, and will save money in the UK healthcare system. So this is the pathway in the UK now. You have coronary CT as a front-line test. If you find disease with indeterminate functional significance, you can go get a HeartFlow test and get information about ischemia. And then the expectation is that we're going to see clinical improvements in cost savings. This is from the NICE webpage, where they evaluated annual savings by top technologies assessed by NICE. This is the change in the chest pain guidelines with the introduction, also the introduction of our technology, the estimated savings in the UK healthcare system, compared to the other technologies that have been introduced or evaluated by NICE. So we're very excited about that and really kind of bringing this forward. This is the pathway in the US. Do a coronary CT. If you find disease, do the HeartFlow test. If that's positive, go on to invasive angiography and physiology measurements if necessary. And we just want to close and tell you a little bit about a few of the lessons learned. First of all, what happens when it's introduced clinically? You actually reduce the catheterization rate by about 50% on average across the clinical studies, all over the world that we've seen. Most of the patients in the catheterization lab get treated rather than just a diagnosis. And then the other question is it safe? So all the data we have so far from the platform study, this is a site in Denmark that has done now about 1,500 patients. So far, no adverse events reported in any patient that they've had where a cath has been canceled. We just had a study presented in Japan with 1,000 patients, 300 of them had a deferred cath. Just as the early time point, but no adverse events. In August of this year, we'll have a study with 5,000 patients where the data will be presented at the European Society of Cardiology on outcomes and reduction in procedures in 5,000 patients. And again, that's presented as it will be a late-breaking clinical trial in the big cardiology meeting. So it also takes those lesions that you find from CT and says, hey, they're not functionally significant. We don't need to take that patient to the cath lab. So it's a reclassification from false positives to true negatives. Works really well with calcium. So now with high disease burden, calcified patients, this is the beauty of deep learning techniques, is that you can basically, with invasive data, which is how we started, you can look at the invasive data, look at the calcified vessel and say, well, I think the boundary's right around here, and you can learn that. You can essentially account for the disease in the vessel, and it works well with high calcium. This is a patient we had from Denmark, one of the most experienced clinical sites. They send us these patients when they can't figure it out. We were able to interpret the lumen boundary, provide a result in that patient. Patients with more and more significant disease, now you can take tougher patients to the CT scanner, image them, and get good clinical data, so that there's more data. And also patients without significant coronary stenosis but diffuse disease through the vessels. This is a paper I wrote last year, and this is a recent paper that came out looking at patients with diffuse atherosclerosis and understand functional significance. So last slide is what's next. What's next, if you take that model, it's going back to this idea of treatment planning. Look at that stenosis, open it up in the computer, predict what's going to happen for that patient. Now take patients with more complex disease and try to predict the benefit of treatment before the patient goes in the catheterization lab. When the patient's in the catheterization lab, it's very expensive procedure. The physician and patient, there's radiation, there's contrast administration, and there's time, a lot of people. If planning can be done before the patient goes in the catheterization lab, our expectation is to be better for the patients, better for the doctors, better treatments ultimately, and lower, hopefully less time, more efficient procedures. So this is coming out at the end of this year, and we've been starting to do single case reports. This is a published paper describing that technology. Just in closing, the technology has been now validated in 4 trials over 1,200 patients. It reduces the diagnostic cardiac catheterizations, but not stenting procedures. Could result in significant cost savings while improving patient care. Now we've had it used in over 20,000 patients. We have some very large clinical trials that are just starting. We'll also be starting one actually our first big trial in the UK is underway, and we have 2 more global trials that are starting. We do this fast enough to provide the results back often in a couple of hours, which is really great compared to the other pathways or tests. I remember where I was, I guess we were talking about Ireland, I think, where the waiting list for a CT is a year and for catheterization is 1 to 2 years afterwards. So, it's a big difference in time. When we rolled this out into Denmark, they had a practice, they would do a CT, a positive CT, they would order a PET study, and it was 6 to 8 weeks afterwards they would get the result. So for them, they upload the data, at the end of the day, they have the result back the next morning. So it's a completely different, scenario for them, and better for the patient. You don't want to be sitting around for 6 to 8 weeks waiting to know whether you have significant disease that might be life-threatening. The technology platform, again, we're doing the virtual planning. We also have a trial that was published on actually predicting the risk of rupture that was published in one of the journal, American College of Cardiology. The imaging journals is a trial called Emerald, where we showed that if you predict the pressure across the stenosis, the coronary lesion, it was actually the single best predictor of whether that plaque would rupture and cause an MI. So that was the first, it's really exciting a study, and we're now doing a much larger study, also using deep learning methods to be able to try to develop new risk predictors for heart attacks. And just in closing, this is a collaborative research agreement with the Imperial College, so it's great to be here. It's my first visit again to Imperial College, and we're starting to look at real estate and expect to build a big tech center in the UK, and look forward to hopefully working with some of you in the future. Thanks very much.